This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1204, recorded on March 27, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
I've seen that bow tie before, but I don't remember what it is. Is it some virus? It looks like particles, yeah.
It's prions, right? And maybe somewhere in your brain there, Vincent.
Misfolded
proteins preventing you from remembering.
Could be.
Could be, actually. A lot of interesting theories about even some of the other dementias being triggered.
I remember a lot of things. The things that are a problem are things I don't use, right? So you meet someone and then you don't see them for 3 months. I can't remember their name.
I'm bad with names. I mean, that's just, some people are just great with names. Some people are not good with names. My dad's always like, oh, if you don't remember someone's name, so you just really don't find them important. I'm like, Dad, that's not true. Just some of us have, of course, he remembers like everyone's name. So, of course, he loves everyone,
I remember lots of viruses too.
And I'm wearing my suit because it's my dad's birthday after this.
Oh, how nice.
Yeah, I'm going to go out to dinner with my parents. So.
Very nice.
Yeah, my mom had a birthday Monday, and my dad is today. So it's. I was thinking about this, because my daughter Daisy is pretty serious with this John Scott fellow, and I'm thinking they should make sure that their birthdays are not too close, because you kind of like they get like the double celebration. Like Tuesday, my two stepsisters, like 15 kids, big like birthday celebration. But was it for my mom? Was it for my dad?
Not much you can do about it if it's already fixed.
Yeah, I guess that's true. So, all right. Well, let me start with a quotation, Vincent. If you talk to a man in a language he understands, that goes to his head. If you talk to him in his language, that goes to his heart. This is by Nelson Mandela. And I think maybe, we are doing our best to communicate, but as we're going to find out going forward, there seems... what's that Cool Hand Luke movie? It seems that we've had a failure to communicate.
Failure to communicate, yep.
They were going to do a remake, but they realized they didn't have the budget to buy all the eggs that Cool Hand Luke eats. That's a joke. That's a joke. But all right. So, measles, as we were joking before we started, measles is going viral. We only get updates from the CDC on Fridays, right? So this is always like a little bit outdated. So total case in the U.S. as of March 20th. So, they stop counting noon on Thursday. They post on Friday. So we're always like, when we record these, always like a week behind. But a week ago, we were up to a total of 378 confirmed measles cases. Reported by 18 jurisdictions with the CDC. We're over 400. But they're talking about Alaska, California, Florida, Georgia, Kansas, Kentucky, Maryland, Michigan, New Jersey, New Mexico, New York. I'm just going to say New York because New York City and New York State, they got like different jurisdictions. Ohio, Pennsylvania, Rhode Island, Texas, Vermont, Washington. And let's go into a few of the places. So Texas is giving us updates on Tuesday and Friday. 327 cases just since January, 40 of the patients hospitalized, not for quarantine because they're sick. Only 2 of the identified cases verified to be vaccinated. The rest are either unvaccinated or they don't know. New Mexico, we're getting Tuesday, Friday updates there. We're up to 43 verified cases per the last post. You can start counting these in your head. Kansas, we have an outbreak in Kansas, and it's doubled in less than a week to 23 cases, possible link to the outbreaks in Texas and New Mexico. Health officials in Ohio say a single case identified in Ashtabula County has spread to 9 others. Even before these 2 growing clusters were reported, the number of measles cases in the U.S. had already surpassed the case count for all of 2024. Ohio, not to be left out, they announced a measles outbreak, right? So we've got Kansas, we've got Ohio. Now, what's going on in New York? Now, New York Governor Kathy Hochul launched a new web portal to provide access on vaccines. Oh my gosh, dare she do that? And public health information after cases of measles were diagnosed in New York. The governor joined State Health Commissioner Dr. James McDonald to update New Yorkers on the cases and encouraged everyone to ensure they are current on recommended immunizations. So I like this quotation. Measles doesn't belong in the 21st century, and it certainly doesn't belong in the state of New York. As measles outbreaks occur at home and around the globe, it's critical that New Yorkers take the necessary steps to get vaccinated, get educated, and stave off the spread of this preventable disease. The safety of our communities depends on it. Been 4 cases of measles in New York State so far this year, 3 in New York City and 1 right out by me in Suffolk County.
That's the right response, Daniel. Get vaccinated, not get vitamin A.
So it really is the right response. And I think we have to have the bravery, the confidence to really stand up and make a nice, clear message. And in this posting, there is a nice, clear section where they talk about vaccines, and they also clarify that early dose. We've had some questions about that. So, and in this New York State posting we recommend that all children get 2 doses of measles, mumps, rubella, MMR vaccine. Children should get their first MMR shot at 12 through 15 months as soon as possible within this time period. Second dose may be given as soon as 1 month after the first dose, but it's recommended between 4 and 6 years of age. And here's this issue that keeps coming up, which I'm going to keep clarifying. An early dose of MMR vaccine is recommended for children 6 to 11 months of age who will be traveling internationally or in an outbreak setting. But these children will still need the 2 routine doses given at 12 to 15 months and 4 to 6 years of age. But I do want to put in that reminder from last week, that study where long-term dynamics of measles virus-specific neutralizing antibodies in children vaccinated before 12 months of age was published in CID. And this is where we saw that there is a downside to that early dose. And in this study, routine vaccination of infants under 8.5 months of age may lead to blunted measles virus-specific antibody responses to subsequent MMR vaccination.
You know, Daniel, it's very interesting. We're getting a lot of emails about measles vaccination, right? We always get a lot about COVID. We hardly get any about flu.
It's really interesting.
I wonder if it's because it's so straightforward or people just don't care.
Well, when we get to the flu section, let's talk about it. I think a lot of people don't appreciate what a serious disease flu is.
Yeah.
Right? And that was one of the issues. Yeah. So, when we get to the flu, let's talk a little bit about the fact that, because people, I remember that article, COVID is bad, comparing it to flu is worse. Flu's bad too.
Of course, yes.
And I think people forget that. We'll talk about the another 10 kids died just this last week. And about half of them were, to all, appearances, healthy kids, and now they're dead, right? So, All right, so why do we care about vitamin A, Vincent?
Oh, my gosh.
Well, so we have the article, Vitamin A in Children Hospitalized for Measles in a High-Income Country, published in Pediatric Infectious Disease Journal. This back in August 2021. So, people probably weren't watching the literature on vitamin A, but this is a really important concept. Is it important to give vitamin A in our current context where we're living in this high-income country? What do we recommend? What's the data? So we do recommend a very specific dose of vitamin A only for 2 days, immediately on diagnosis, under the supervision of a physician. You get 1 dose, you repeat it the next day for a total of 2 doses. And there are specific doses that have been studied and shown effective in specific contexts. So 50,000 IUs for infants younger than 6 months, 100,000 for infants 6 to 11 months, 200,000 for children 12 months of age and older. But all those recommendations are based on data from areas in the world with significant issues with vitamin A deficiency. So what about children here in the US or other high-income countries without significant vitamin A deficiencies? Does it make a difference? Is it helpful? Is there just risk? Well, these results in the study are from a prospective controlled cohort study involving children admitted for measles to a tertiary care hospital in Italy, southern Italy. A total of 108 inpatient children were enrolled. 36 received the 2 doses of oil-based vitamin A, according to the age guidance. 72 matched controls received no vitamin A, and there were no significant differences between the study groups in duration of fever, length of hospitalization, maximum body temperature, rate of organ or hematological complications, or need for antibiotic treatment. Overall, vitamin A did not reduce the risk of any complications. So they concluded that vitamin A does not change the clinical course of measles infection or the rate of complications in children hospitalized in high-income country.
Miraculous recovery, he said.
Yes. So why do we care? Well, we care because, unfortunately, people are spreading misinformation and children are being hurt. And I just want to point that out because of this misinformation, because either people don't have a conscience or they're just none so bright or they're not willing to put in the work to get accurate information. There are folks out there spreading misinformation. And we have this article, Remedy Supported by Kennedy Leaves Some Measles Patients More Ill, in the New York Times. Doctors in West Texas are seeing measles patients whose illness has been complicated by an alternative therapy endorsed by vaccine skeptics, included Robert F. Kennedy Jr., the health secretary. Physicians at Covenant Children's Hospital in Lubbock, Texas, say they're now treating a handful of unvaccinated children who were given so much vitamin A that they have signs of liver damage. Some of them received unsafe doses of cod liver oil and other vitamin A supplements for several weeks in an attempt to prevent measles infections, said Dr. Summer Davies, who cares for acutely ill children at the hospital. At high doses, vitamin A can cause liver damage, dry, peeling skin, hair loss, seizures, coma. West Texas doctors have seen little children with yellowed skin, high levels of liver enzymes in their blood. Health officials said the recent popularity of vitamin A use for measles is actually traced back to a Fox News interview with Mr. Kennedy, in which he's sitting there in that burger joint, right, eating fries that were deep fried in beef tallow. And he's saying, almost miraculous and instantaneous recovery with treatments like cod liver oil, which he said was the safest application of vitamin A. And as we were pointing out, in fact, giving children repeated high doses of vitamins is dangerous. Unlike other vitamins which flushed out of the body through urine, excess vitamin A accumulates in fat tissue, making it more likely to reach dangerous levels over time.
If he were a doctor, this would be malpractice. But you can actually be charged with malpractice and acting like you're a physician. The guy who's going to run the new autism study has been accused of that.
Yeah, he's actually, I'm not sure what exactly were the punishments, but yeah, there are people out there who practice medicine
without an MD.
Without an MD, without a license, without a DO, they just, and basically here in this position as the head of the HHS, Kennedy is hurting more children again.
Yeah. And
so,
he's going to do stupid things. He needs to be fired, Daniel. I'm sorry. It's just, he's harming people's health. Yeah.
I mean, he's harming children. Right. And we already have one dead child. We already have one dead adult. We have over 40 people hospitalized so far. There's a point when, no, and I think it gets back to what we were saying early on, is people need to stand up. People need to say something. I know that, you and I, we get like the death threats and the legal threats and all the rest, but, we have to keep standing up because, this matters. This really matters. So, all right, well, I'm going to leave in, I guess we'll put in our show notes that really nice vaccine table from New York Presbyterian.
Yeah, you have to send it to me. You didn't send it, I think.
Okay, it's right in my show notes here, so.
I can't get it out of there.
Can't get it out of my show notes. I'll send it to you, Vincent. All right, so it's in my
Send it
show
to me,
notes. I'm
buddy.
going to send it to Vincent. We'll have it in the show notes. Then everyone can see with all the nice references as well. All right, moving on from the measly disease to avian flu or bird flu, or dare we call it sheep flu?
Gosh.
Because now we have bird flu in sheep. The UK Department for Environmental, Food and Rural Affairs, DEFRA, announced Monday, the 24th, the UK's first avian flu detection in a sheep on a farm in Yorkshire, where an outbreak has been confirmed in captive birds. The female EWE, had mastitis. The animal's milk was positive for H5N1 on PCR testing, and a blood sample was positive for H5 antibodies. And I've got a cute little photo here.
Very cute.
You like it? It's from CIDRAP. It's from
very
friends, Minnesota.
By the way, Daniel, it's Yorkshire.
Yorkshire? Like the pudding.
Yorkshire pudding, not Yorkshire.
Okay.
Yorkshire.
Just like the pudding. All right. Okay, so what are we going to do? Well, the USDA is going to invest $100 million for projects to combat bird flu. That's not a lot. So let's discuss this. So we're going to throw a bunch of money. The U.S. Department of Agriculture said it plans to invest up to $100 million in projects that will help fund research for therapies and potential vaccines to combat bird flu in poultry. I'm not sure how this is going to work, right? Because we actually just had all the research NIH funded with the word vaccine canceled, so I don't know how this is somehow going to squeak through if you can vaccine but bird flu. The U.S. also began, and I don't like this, importing eggs from South Korea, more eggs from South Korea, along with eggs from Turkey and Brazil. So the U.S. has gone from this robust, high-income, first-world country to now South Korea, Turkey, Brazil, and others are sending us eggs because we can't actually meet our egg supply demands. It's embarrassing. Now, the USDA has not approved the use of a vaccine, but said on Thursday of last week, it is seeking vaccine candidates that are well matched to circulating variants. Kennedy, a longtime vaccine skeptic, has said in media interviews that he does not support a bird flu vaccine and that the virus should instead be allowed to spread among poultry to identify birds with natural immunity. Asked about whether Rollins agrees with Kennedy, her chief of staff said the two secretaries are aligned on approach. The U.S. egg industry wants farmers to be able to vaccinate laying hens, turkeys, and potentially dairy cows. Chet Gregory, CEO of the United Egg Producers Industry Group, tells us.
What the hell does that mean, aligned on approach, when they totally disagree? I mean, if the USDA wants a vaccine and RFK does not, that's not aligned on approach.
It's it's all this like wordsmithing stuff, that they do, where they just they
just lie all the time. There is a USDA approved H5N1 chicken vaccine, but they don't use it. Okay, they just, for various reasons, they don't want to use it, and now it may not even match the current strain. I don't even know. There's a company. It's made by a company called Zoetis.
And it's stockpiled, right? It's sitting there. Didn't we already pay for it? Yeah,
and they're making a new one to match the currently circulating one. So, but I don't think a vaccine is the same. Although avian flu vaccines are used in other countries. But I don't know. I think you have trouble selling your chickens if you've got virus in your flock. And, no vaccine is 100% effective. So I think it's a real problem.
It's interesting because so that was the argument before. Well, if we vaccinate them, then no one's going to want to buy our eggs. No one's going to want to buy our birds. We don't even have enough eggs to meet our own supply. We're not exporting eggs at this point. We've turned into a country that can't even. They were making fun of us overseas about, oh, I understand you guys are all going to start raising chickens in your backyard because you can't feed yourselves. I'm like, oh my gosh, it's embarrassing. Yeah. Okay, and that's not political. We're talking about science. All right.
It's all science.
It is science. And that's the problem. You need a scientist in the room when you're trying to make these decisions about how do you combat bird flu. Let's call a politician. Let's call a lawyer.
The head of the Department of Agriculture is a politician and lawyer, not a scientist.
Yeah, this is a science problem. Yeah,
the Department of HHS head is a lawyer also, not a scientist. This is all these people in these positions are totally unqualified.
Yeah.
Every one of them.
Yeah.
Even Bhattacharya, I'm sorry, just because he's a Stanford professor, He's done screwed up things. He's totally unqualified.
Yeah. No, it's
Sorry.
a problem. It's like the next time that you're feeling really bad and, maybe you break your leg or your car accident, like go see your lawyer, right? I mean, no one would do that. It's silliness. You go to someone who's trained, who took an oath, who actually knows how to combat disease. So.
Well, that's the thing that, RFK is involved in these Gardasil lawsuits, right? They have these ads. If you were injured by Gardasil, call us. It's like, the hell do you know if you're injured or not? What, you get a Gardasil shot, you walk out the door and you get hit by a car, and then you're going to call them? I was injured by Gardasil. I mean, Gardasil is totally safe, right?
Well, there was an amazing, I'm looking forward to this presentation at the end of the month, but this really robust study looking at HPV infection and cardiovascular disease. And there's like a 50% increase, like a doubling of cardiovascular events in people that are HPV infected versus people who are not. So, right now, it's a cancer vaccine, and people are worried if someone gets the vaccine, they'll have more sex. But what about people not wanting to have heart attacks? What about when it extends there? So, here's an opportunity to protect your children from cancer, from end up having a heart attack, maybe even a stroke. So,
there's no injury by Gardasil. What the lawyers try to do is make stuff up. And then the jury can't figure it out because they're not scientists either.
Well,
right?
It's hard. Yeah. I mean, so I was talking to a pulmonologist today. He's a bit of a character. And he was telling me about his son, ended up with myocarditis back in October. And, they did some blood tests and they figured out like the serology came back like off the charts. It was Coxsackie virus induced. And I was like so glad his son was an anti-vaxxer because otherwise it would have been, but it's like everything, like, oh my gosh, when he was wearing a hat and he roots for the Mets. And so, you never really know. I'm like, yeah, it was the virus. The virus caused the myocarditis. It had nothing to do with vaccines, which sports team he roots for, So, all right, influenza. Influenza activity is still high. But it actually, it's high only in certain areas, right? So we're starting to see some green, Montana, the Dakotas out there kind of in the upper Midwest. Here in New York, we went from very high to high. So, a little bit of light there. The trends over time, when you look at ER visits, it is coming down. I think we're on our way out of the season. But I do want to point out, and this gets back to this, the flu is bad. And maybe people don't know this. So I was looking at the CDC and the CIDRAP updates, right? So I'll leave the link into both. So, if you look at CDC, they are reporting another 10 pediatric influenza-associated deaths just this last week. Per the CDC count, we're up to 57 deaths this season. CIDRAP, I don't know where the data is disparate, but CIDRAP is reporting 17 more pediatric flu deaths this past week, giving us a total on their count of 151 children dying of flu so far this year. I don't know if they're using a different age versus, younger. They're including adolescents. But the previous flu seasons per CIDRAP, 187 and 207 pediatric flu-related deaths. So I'll leave in links to those. But, as I keep pointing out, about half of these kids are completely healthy before they get knocked down by the flu and leave us. And children should not die. And I always point out, 90% of the people that die from flu did not get their flu shots. And we're getting worse and worse at getting those flu shots.
I think it's a media thing, Daniel. Going back to this idea that people don't seem to care about flu. COVID, big deal, pandemic. People still worried about it because of that. Now measles is in the news, so people are worried about that. If there were an Ebola outbreak in the U.S., people would say, "Where's my vaccine?" But flu is not really in the news, right? Because it's been around forever and it's not newsworthy, and so people don't think about vaccination. That's what I think.
That's the problem with the free press, Vincent.
Well, we always complain about it, but we don't say they shouldn't be reporting, right? This is free speech. They should be able to do this.
Yeah. It's not a question of a free press. It's a question of, it's driven by the capitalist model, right? They're not going to print articles that people are not going to read. And so it is really
something like CIDRAP, they don't worry about income. They just print information, right? Because they're affiliated with the university there. So I think they report whatever they see, and I think that's the way to do it. It's not a newspaper, right? It's solely health focused.
Yeah. And same as us, we're bad capitalists, right, Vincent? We're actually just, talking about what we think people need to hear about. So, and I'll also leave in our flu vaccines. We have our composition for next year. So, what is it? Vaccines don't save lives. Vaccinations do. So, come next fall, let's try to do a better job than we did this last year. RSV. So RSV is still high, but going down when we look at ER visits across the country. So we're moving in the right direction. Next week I'm going to put in, just sort of came out today, I haven't had time to really go through, but looking at the success of RSV vaccination in the UK, like a 30% reduction in hospitalizations just from vaccine. And that's huge. Those are like people that are still able to stay at home or work or help out with, childcare, or do productive things. And all the avoided hospitalizations. So that hospital bed is there for you if you get sick. If your lawyer can't fix you up, right? So you need a real doctor. All right, COVID update. I was thinking we were going in the right direction, but COVID went from moderate to high over the last week, looking at wastewater. And actually looking at the trend over time, you can actually see in the South, it started to come back up a little bit. In the Midwest, it started to come back up. Nationally, it's kind of plateaued to a little bit of a rise. And I have to say, when I was mentioning this to a colleague of mine who works in the urgent care setting, he was like, strange that you mentioned it. We're starting to see a lot of COVID. So
hey, we just got out of spring break. That's it.
I hope that's what it is.
My class came back this week, and yesterday I said, don't give me any of your infectious diseases that you picked up wherever you went. That's how it happens, okay? You go to spring break somewhere else, you pick up stuff you've never seen before, and then you give it back home, right? So that's why we're probably doing this.
Yeah. Well, let's blame it on spring break. You sure it isn't that there's some new, highly transmissible, less virulent variant or something? Really?
No, most of the time it's human behavior.
Yeah.
That's it.
All right. So, yes, transmission. Let's talk about that. How do you actually get infectious diseases? Apparently, it's not from wet hair, but you actually
miasma.
Germ theory, Vincent. Invisible things, microscopic things that you can't see make you sick. The article, Lower Levels of Household Transmission of SARS-CoV-2 Omicron Variant of Concern versus Wild Type, an interplay between transmissibility and immune status, was published in JID. These are results from a household cohort study, prospectively assess the impact of the BA2 variant and immunity on household transmission. 67 households were included, 241 individuals. The maximum household SAR, secondary attack rate, was 59.7%. Per person, SAR was 41.5. Are you ready for this? Pediatric index cases were more likely to transmit. Remember all that ideas that like, oh, you can't get it from kids. Kids can't get COVID. Kids can't transmit. Oh my gosh. And transmission was negatively affected by household members' immunity. So,
wow, who would have thought that?
Who would have thought? So, I thought it was all about the variant. So, all right. Now, it's a special section here for Rich Condit. I'm not sure he's listening to my clinical updates, so I'm going to send this to him. But another article, Does COVID-19 Vaccination Reduce the Risk and Duration of Post-COVID-19 Condition?, published on the European Center for Disease Prevention and Control site. And I enjoyed the line from CIDRAP, their commentary. COVID-19 vaccination slashed the risk of experiencing prolonged symptoms by about 27% in fully vaccinated adults who were later infected. Estimates of a European CDC, so it's a European Centers for Disease Prevention and Control, systemic review of 12 studies. And in this news release, Edoardo Colzani, he's an MD, a PhD, an MPH, and the head of respiratory viruses and Legionella, said, an important takeaway from this review is that vaccination not only protects against severe outcomes of acute illness during a pandemic, but may also help reduce the risk of significant long-term effects. So what are the current COVID-19 vaccine recommendations? Someone send a link to Rich Condit, please. Routine COVID-19 vaccination. These are the CDC and my endorsed recommendations. Children age 6 to 4 years. If you're unvaccinated, you get that multi-dose initial series. If you're previously completed that, you're going to get one dose of the 2024 mRNA vaccine. People aged 5 to 64, that's me, should receive one dose of an age-appropriate 2024-2025 COVID-19 vaccination. Everyone, you saw that? People aged 65 years and older should receive 2 doses. So you get that one dose in the fall, you get another dose 6 months later. And people who recently had a SARS-CoV-2 infection might delay that vaccine dose by 3 months. So Rich Condit, if you're listening, I'm going to send this to you. Everyone over 65, I think Rich is over 65, right?
Yeah, he is.
If you got your last dose in September or longer ago, then the CDC, and I still recommend you get one now. If your last dose was October, then next month, April is a good time for you. And I like that October-April cadence. All right. And we'll keep talking about the data, but I think it was Mike Osterholm. I listened to his podcast too. He was echoing what we've talked about. Unfortunately, the vaccines, it's not a one and you're done in lifetime. Getting that booster gives you an extra 30 to 50% reduction in medically attended COVID-19. And as we mentioned, even in the lingering long COVID stuff. All right. Early viral phase. You get COVID. And here I'm going to throw in a John F. Kennedy quote. The time to repair the roof is when the sun is shining. So don't wait for the rain. Don't wait for the cytokine storm. It's the first week when you want to jump in. And so number one, Paxlovid, the article, the effect of nirmatrelvir/ritonavir on short and long-term adverse outcomes from COVID-19 among patients with kidney disease, a propensity score match study published in CID. So results of a cohort study evaluating adverse outcomes in patients with kidney disease who developed COVID-19. A total of 1,095 nirmatrelvir/ritonavir treated patients were matched to 584 comparators. Patients who received nirmatrelvir/ritonavir were less likely to be hospitalized within 30 days of diagnosis. We get a hazard ratio of 0.44, so 56% reduction. And at 1 year, the treated folks had a lower risk of hospitalization for major adverse coronary events. And that was a 51% reduction. And death, that was a 63% reduction. So vaccines and early Paxlovid. All right. And then if you can't do the Paxlovid, and I will point out, we have the PAXS, PAXCESS program. I got a call Monday night from a high-risk individual, ordered up the Paxlovid. They went to the pharmacy. $1,400 is what they were going to charge them. They check with their union, person who does the benefits. No, it's not covered with our plan. They went on. A few minutes later, they printed out a coupon, and it was free, $0. So, if you get hit with that, go to PAXS, type in a few things, and they'll help you out. All right, remdesivir, molnupiravir, convalescent plasma, and then a number of options for that second inflammatory week. But again, let's treat while the sun is shining before the storm. All right, a bunch of things on long COVID. So, number one, the effect of pulmonary rehabilitation for patients with long COVID-19, a systematic review and meta-analysis of randomized controlled trials published in the journal Therapeutic Advances in Respiratory Disease, a total of 37 RCTs with 3,363 patients included. The primary outcomes were physical capacity, assessed by 6-minute walking times, that's where 6 MWT, lung function measured by forced expiratory volume in the first second, FEV1, and forced vital capacity, FVC. We also have health-related quality of life and fatigue, and then a bunch of secondary outcomes. And compared to controls, The pulmonary rehab actually improved physical capacity by a number of these measures. Lung function, right? So you've got really nice objective measures. Fatigue, dyspnea, and anxiety did not reach statistical significance for depression. Subgroup analysis indicated that programs of less than 4 weeks improved the 6-minute walk time. Go on to give us a lot of other encouraging data supporting the role of pulmonary rehab in a subset of patients. Now, a fun article I was going to say to end this week before I got like another bit of bad news, but I was going to end on a fun note. Wearable data reveals distinct characteristic of individuals with persistent symptoms after a SARS-CoV-2 infection, published in Digital Medicine. They start with the introduction. Data from wearable devices such as smartwatches or fitness trackers offer a novel approach to understanding the long-term impact of SARS-CoV-2 by providing objective measures of heart rate, physical activity, step count, and sleep duration. During the COVID-19 pandemic, several initiatives were launched to collect such data. One such initiative is the Corona Data Donation Project by the Robert Koch Institute, the famous Robert Koch. What did he invented, like a soda, or he like really locked in the germ theory thing? One of those. I think it was the latter. Germany's Federal Agency for Public Health Research. Between April 2020 and December 2022, over 500,000 voluntary participants registered for the project. Over 120,000 submitted more than 600 days of their basic wearable data. And I will say, no real surprises here. They identified individuals with self-reported persistent fatigue and shortness of breath after SARS-CoV-2 infection, compared with symptom-free COVID-19 positive and negative controls. These individuals had higher resting heart rates and lower daily step counts prior to SARS-CoV-2 infection. So basically, people who are more fit going in, there is some degree of protection. In addition, persistent fatigue and shortness of breath were associated with a significant reduction in quality of life even before infection. So people who are not doing so well. But I was more interested in the report that individuals with persistent symptoms exhibited on average more pronounced bradycardia up to 18 days after the positive SARS-CoV-2 test. All right, and long COVID office will be closing, Trump administration announces. So this is from an email. Actually, I'd heard about this a little bit ahead of time, but the email was sent by Ian Simon Monday, the head of the Office of Long COVID Research and Practice. And it said the closing is part of the Department of Health and Human Services reorganization. This follows on last month's executive order terminating the federal agency's Committee on Long COVID.
This is a dumb move.
You know, what's really tough, and maybe it's, somebody lies a lot, is during their confirmation hearing, they committed to continuing, long COVID research. And this is not consistent with an ongoing commitment to understanding long COVID and finding therapies for these folks that are still suffering.
No. Yep. Yeah. Lied to get confirmed. Say anything that will get you confirmed. Yep. That's it, Daniel. So
write to your congressman, congresswoman, particularly if you're in a state where that might make a difference.
Yep.
Now, I'm going to wrap us up with the low and middle income countries. No one is safe until everyone is safe. Our listeners may be aware that I'm just back from the Bocas del Toro archipelago, where I was working with the floating doctors and the indigenous people. So the current situation with global health was a topic that we were talking about every day. Lots of discussion about soft power and leaving a vacuum to allow for a growing Chinese influence in many of these regions. But more immediate to me and my colleagues has been the direct impact on the people in these areas that were supported by this aid. My daughter Daisy, who was with me on this recent trip, sent this article from the New York Times. Musk said no one has died since aid was cut. That isn't true. It's an opinion piece, so let me try to sift down to the information we have here. I'm going to try to make this less partisan. I got that highlighted in yellow because I know this is a very emotional topic. And the author, Nicholas Kristof, presents the stories of real human suffering and deaths. So for some of our younger listeners, parents might want to skip ahead of this because I felt this really disturbing. And these are a few stories of people, individuals. So Peter Donde was a 10-year-old infected with HIV from his mother during childbirth. But American aid kept Peter strong even as his parents died from AIDS. A program started by President George W. Bush called PEPFAR saved 26 million lives from AIDS. And one of those was Peter's. Under PEPFAR, an outreach health worker ensured that Peter and other AIDS orphans got their medicines. Then in January, Trump and Musk effectively shuttered the U.S. Agency for International Development, perhaps illegally, and that PEPFAR outreach program ended. Orphans were on their own. Without the help of the community health worker, Peter was unable to get his medicines. He became sick and died in late February. The immediate cause of death was an opportunistic pneumonia. As Peter's viral load increased, his immunity diminished. We hear this from Moses Akani-Labani, a health outreach worker who helped manage care for Peter. If USAID would be here, Peter Donde would not have died. Another story of Akol Dang, an 8-year-old girl, also infected with HIV at birth, likewise remained alive because of American assistance. January, she lost her ID card. There was no longer a caseworker to help her get a new one. Couldn't get her medicines. She too became sick and died. Another household kept alive by American aid was that of Jennifer Inya, a 35-year-old single mom, and her 5-year-old son, Evan Anzu, both of them HIV positive. Last month, after the aid shutdown, Inya became sick and died. A week later, Evan died as well, according to David Irasimon, a community health worker. They go on to share other stories, but this piece has a number of these firsthand accounts of individuals dying. I find this even more compelling than the estimates of 1,650,000 people that are expected to die each coming year without foreign aid for HIV prevention treatment, or the millions that will die from starvation, malaria, tuberculosis, and other diseases. The piece concludes with, when you meet these dying children and look into their eyes and hold their hands and feel faint heartbeats flutter, you can't bear the gleeful laughter. You see children just like your own and hang your head in shame. So I do want everyone to pause the recording right here, go to parasiteswithoutborders.com, click that donate button. Even a small amount helps. Every bit helps us to continue to do our work. Right now, we're doing our Floating Doctors fundraiser. We're not doing that well, Vincent. We're not getting a lot of donations. So we're really going to need people to step in to reach our goal. I was down with Floating Doctors. They were talking a lot about cultural competence, how easy it is to do harm, discussions of the difference between good advice and helpful advice, a lot of discussion about really maintaining good relationships with our patients, avoiding medical gaslighting. We haven't done so great there. Recent survey, 94% of respondents reported instances in which they felt their symptoms were being ignored or dismissed by a doctor. So let's try to do a better job. Otherwise, we are leaving a vacuum for misinformation and all the other folks out there who, as we see, are harming our children.
PEPFAR, as you said, was started by George Bush, who was a Republican. He had compassion and humanity, and it's very different from today's Republicans, who seem to have none. There's no reason to cut off this aid and have people die. And even worse, I don't understand why you have to lie about it and say no one has died. Why the lies? And we see every day lies from this administration. It's disgusting.
Yeah, I'm a huge fan of George Bush. I actually did some work when they were trying to revamp the way doctors were getting paid, the whole pay-per performance. I just don't think he gets enough credit for what he's done. And what a shame to see. He built such a tremendous thing. He made such a huge difference, and to see it torn down by his fellow Republicans. So.
Well, it's clearly unconstitutional, but it takes so long to reverse it that the damage is already done.
Yeah, the damage is already done. These children, we can't bring them back. They've already died.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Karen writes, I listened to TWiV 1202 and saw the chart. This is the New York Presbyterian measles vaccination chart. I was born in 1963. I had 2 shots of the old inactivated virus in the mid-'60s. Then in 1977, because of the measles outbreak in Los Angeles, which caused California public schools to require vaccination, which was then offered by the Public Health Department for free, a triumph of public health. I had a shot of the attenuated virus. What do you make of this combination of inactivated and attenuated? Do I need another dose of the attenuated vaccine?
Let's go look at our chart and see if it helps us sort through this. So let's see. So you fell into that situation where vaccinated between 63 and 67 when less effective killed vaccine was used. And the measles vaccine recommendation is 1 MMR dose recommended.
Which she got in 77, so she's good, right?
Thumbs up. It's interesting, and I think people, this came up in the in an ICU rounding just the other day because, we recently had some of my colleagues get exposed with the child over at Cohen's Children. And, we throw out these numbers like 94, 97%. But I have to say, people like you, people who've gotten 1 MMR vaccine after that prior, you're not going to end up in the hospital. You're not going to die from measles. So you're in good shape.
Susan writes with a correction. In TWiV 1202, you mentioned that we have yet to see transmission from a backyard flock to a human. But she sends links from the Louisiana Department of Health and the CDC, who have determined that patient had a backyard flock and was exposed to sick and dead birds, so that's the first case of H5N1 bird flu in the U.S. linked to exposure to a backyard flock.
Wow. So we shouldn't be like having the hens in our backyard.
It's one, Daniel.
No, but Susan, I appreciate you sending the link for that.
Charmaine writes, in the fall of 2023, at the age of 70, I received an RSV vaccine at the local drugstore, no questions asked. This past fall, I went to get another one and told I wasn't eligible because I wasn't 75. I recall you're saying that the study showed that the vaccine is probably good for 2 years, but the CDC recommends receiving only one for life. This coming fall, I'll be 72. It will have been 2 years since my previous shot. What do you currently recommend as to whether or not we should get one every 2 years? And if so, should I say I have a pre-existing condition in order to get the damn thing?
Okay, Charmaine. So here's the data that we have. So we, as time goes by, we get more data. So we have 3 options, actually, 3 different vaccines. So, the RSV vaccine that you got, I'm assuming it was not the mRNA, but one of the others. It looked like, at 1 year out, it was still okay. It looked like 2 years. We haven't seen the recommendation yet. We haven't really seen the data, what happens. There was a little bit of interesting data where some people had got another shot after 2 years, and we really didn't see it. And you think, I got a shot, it'll bounce me back up. We didn't see really much of a bounce back. So we don't know, but by next fall, when it comes time for you to make this decision, we'll certainly circle back. So keep listening. And when I have more information and give you some better guidance, I will certainly do that.
Evan writes, I wrote to you several years ago about cognitive decline after acute cases of COVID and asked whether that decline, now documented in long COVID patients, is additive. I don't believe you ever addressed this issue on TWiV, slightly reduced IQ, cognitive decline issues, etc. I read about the quantitative measures of these declines, but I've not seen studies or data about whether these declines are additive with repeated bouts of COVID. Does that data exist, or are there ongoing assessments of this?
I'm a little worried that we're not going to get a lot of ongoing assessments if we're shutting down all this research. I know people have heard, but I got a list of like all the NIH grants that have been shut down, and unfortunately, there's sort of these like hot button words that caused cancellation. And so a lot of researchers got a letter from someone above their program officer saying, we have canceled, your grant. And what were the hot button words? COVID, infectious disease, virology, vaccines, mRNA. So I'm concerned that we're not going to get this data, but this is data that we've been collecting. So there is concerns that the declines are additive with repeat COVID infections. Sort of the idea that your first COVID infection, so the data we do have, you lose a certain amount of IQ points, and then you lose little the next time. And I think I mentioned that the head of the study section when I was in Bangkok actually went through this data, and he was sort of like, okay, I've lost this many points based upon the different numbers of infections he's got.
And Michael writes, I was born in the early 80s. According to my records, I've had MMR as a child and then in my teens. I had serology done for measles and rubella a few years ago. Rubella came back showing serology. Measles was equivocal. Does this mean I should get another MMR?
So it's interesting. So the measles serology, right? So we talk about all this data that the MMR has 93, second dose 97 protection. But remember, this is protection against disease. You're even better as far as severe disease, hospitalization, death, etc. Serology is recommended for folks in the healthcare setting. But as we've talked about, there's T cell immunity as well. So what does that really mean if you're not in a healthcare setting, if you're not in a high risk situation, if you've got your MMR vaccine as a child? Now, in a healthcare setting, the recommendation, we go ahead and we give you another MMR. Some people are non-responders. Some people get another dose and they just, the antibodies don't come up. So a lot of this recommendation is based on context. If, let's say, you're there in West Texas and everyone around you has got measles and you've got a negative serology, be reasonable to discuss getting another MMR in a context like that.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.